Hello and welcome to the topic Late-Onset Congenital Adrenal Hyperplasia in the Endocrinology module. By the end of this topic, you should be able to define late-onset congenital adrenal hyperplasia, explain the pathophysiology of this condition, outline the causes of late-onset congenital adrenal hyperplasia, describe the clinical manifestations, outline the investigations done, discuss the principles of management, and finally discuss the complications and prognosis of late-onset congenital adrenal hyperplasia. Let's get started. Let's begin by defining what this condition is. It is a common autosomal recessive disorder in which there is a deficiency in the 21-hydroxylase enzyme. Its clinical features predominantly reflect androgen excess rather than insufficiency, leading to an ascertainment bias favoring diagnosis in females, giving the name non-classic congenital adrenal hyperplasia. This is a milder and later onset of a genetic condition known as congenital adrenal hyperplasia. So first of all, there would be a mutation in the P45C21 gene, which in turn decreases its activity, impairing the conversions of 17-hydroxyprogesterone to 11-deoxycortisol and progesterone to deoxycorticosterone. As a result, this will impair the biosynthesis of cortisol, leading to the loss of cortisol-negative feedback inhibition, causing increased secretion of hypothalamic corticotropin-releasing hormone and pituitary adrenocorticotropic hormone. Excessive ACTH stimulation also results in fasciculata reticularis zone hypertrophy, causing adrenal hyperplasia and possibly increased adrenocortical nodularity. To bear in mind that individuals with late-onset congenital adrenal hyperplasia generally have adequate mineralocorticoid secretion. This then causes increased androgen secretion, impairing the hypothalamic sensitivity to progesterone. Thus, there is a persistently rapid GnRH production favoring LH hypersecretion and hence giving rise to the clinical manifestation which we'll be discussing soon. The causes of late-onset congenital adrenal hyperplasia are predominantly genetics where there is a mutation of the CYP21A2 gene, and rarely it may be caused by adrenal tumors. Symptoms-wise, patients usually have normal genitalia at birth. The clinical manifestations may, however, develop anytime after birth. Women with this condition may have virilizing symptoms such as acne, hirsutism, frontal baldness, delayed menarche, menstrual irregularities, and infertility. Meanwhile, men with this condition may complain of early beard growth. When we think about the signs, women usually present with premature development of pubic hair. They may have a tall stature and reduced adult height. In addition to that, some girls may have clitoral megaly without genital ambiguity. Men, on the other hand, will have tall stature and a smaller testis, being on the lower scale of the Tanner staging. Just a quick recap, Tanner staging is basically an objective classification system that is used to track and document the development and sequence of secondary sex characteristics in children during puberty. Generally, the pathognomonic signs would be virilizing manifestations as described earlier on, growth spurts of more than 95 percentile, and scoring lower in the Tanner staging. Now, investigations-wise, evaluating the concentration of 17-hydroxyprogesterone is diagnostic. Evaluating the concentration of 17-hydroxyprogesterone is diagnostic. This can be done in concordance with an ACTH stimulation test. First, you will measure the initial concentration, which acts as your baseline measurement of 17-hydroxyprogesterone. Then you administer synthetic ACTH and repeat the measurement of 17-hydroxyprogesterone 30 to 60 minutes later. In the case of late-onset congenital adrenal hyperplasia, you will notice an increased level of 17-hydroxyprogesterone after ACTH stimulation. There are other investigations that can support the diagnosis. Beginning with lab tests, you may order a genetic testing to look at the mutation in the CYP21A2 gene as mentioned. Next, you can measure the serum androgen level where you'll expect a high androgen level in this case. Lastly, measurements of serum LH and FSH levels may also be helpful. Here, the LH levels are expected to be high. Next, there are some imaging studies that may be useful. CT scans of the abdomen may be ordered if you are suspecting an adrenal tumor. A transvaginal ultrasound should also be ordered in the case of women with late-onset congenital adrenal hyperplasia, as 1/4 of them may have features of polycystic ovary. This is a CT scan imaging that shows an adrenal tumor supporting the diagnosis of late-onset congenital adrenal hyperplasia. Management-wise, the goal would aim to include normal linear growth velocity, rate of skeletal maturation, no delay in reaching puberty, and appropriate weight status for children and adolescents. In women, you would aim to regularize the menstrual cycle and prevent the progression of hirsutism and acne, as well as address issues regarding fertility. The appropriate pharmacological therapy include glucocorticoids therapy, contraceptives, anti-androgen and ovulatory agents. Glucocorticoid therapy is indicated in cases with advanced skeletal maturation. It is essential to ensure close administration to avoid any iatrogenic adrenal suppression. Contraceptives are given when there is oligomenorrhea, acne, or mild hirsutism in adolescents. In an adult woman, ensure that she is not seeking fertility. You can provide anti-androgen agents where there is excessive growth hair, and ovulatory agents when you are aiming to help women with subfertility issues. Surgery is indicated in cases of confirmed adrenal tumor in order to resect the tumor if they are operable. Now, this condition may cause some complications. One of them is precocious puberty, which is due to raised androgen, FSH, and LH levels. Some patients may have tall stature as there is raised growth velocity in view of raised androgen levels. Subfertility is also a common complication, and this is due to the high levels of androgen disrupting the normal menstrual cycle. Lastly, patients may also experience cosmetic inconvenience due to the virilizing features of late-onset congenital adrenal hyperplasia, as mentioned earlier on. Patients with this condition generally have a good prognosis. Thankfully, it is also not life-threatening and is relatively mild compared to classical congenital adrenal hyperplasia. Some women may not even have any symptoms and signs of the conditions, while others may require treatment for hirsutism, infertility, or other health problems. Men, on the other hand, might have very minimal signs with reserved sperm counts. So, in summary, late-onset congenital adrenal hyperplasia happens due to the 21-hydroxylase deficiency in a milder and later onset form of a genetic condition known as congenital adrenal hyperplasia. It is caused by mutations in the CYP21A2 gene and is inherited in an autosomal recessive manner. Few patients may be asymptomatic while others experience symptoms of androgen excess, which may include hirsutism, frontal baldness, delayed menarche, menstrual irregularities, and infertility. Women with this condition are generally born with normal fetal genitalia. However, little has been published about males. They may have early beard growth and relatively small testes. Typically, they have normal sperm counts. Evaluating the concentration of 17-hydroxyprogesterone is diagnostic. Treatment is only indicated in people who have symptoms, and this may include glucocorticoid therapy, contraceptives, anti-androgens, and ovulatory agents. Complications include tall stature, precocious puberty, and subfertility. And most of the time, late-onset congenital adrenal hyperplasia has a good overall prognosis. We have come to the end of this topic. Thank you.